Oh, there we are. So good morning, everybody. It is pretty early for me here. I'm in Phoenix, Arizona, but good morning. Like Mike said, my name is Sean Rutledge. I'm with Edison Healthcare. I'm the president of sales, but I am also the managing partner. I just like the sales side of things and get to be able to communicate with everyone, and that's the fun part of this job. So nonetheless, I'll give you a little bit of history of Edison, kind of how we got to where we are today, the what would Walmart do sort of how, and then I'll just sort of dive right in. And y'all feel free to ask questions either through the chat or just interrupt me. I don't really care. So nonetheless, Edison was founded about 10 years ago by a guy named Tom Emmerich. And maybe you've heard of that name in healthcare, maybe you haven't. He was head of global benefits of some of the biggest employers in America. So yeah, Diageo Foods, British Petroleum, and then his real claim to fame came from running Walmart's benefit plan for years and years and years. And, when Tom took over that plan, Sam Walton, who hired him, the founder of Walmart, really tasked him with doing two things. Tom, we want you to lower the overall healthcare spend and improve the quality of the benefits. So shocker, that's healthcare in America, but that is definitely Walmart. And so what did Tom do? Being the old actuary that he is, he started digging into the data because data really is kind of everything. And what did he quickly realize going back 10 years of data and millions of lives on the health plan? He noticed that about 6 to 8% of his population was spending all the money. And so Tom said, okay, I've identified where my biggest problem is, the biggest risk on my health plan. Now, where in the world are these people going? And in kind of a typical PPO or network type of arrangement, folks are just kind of going wherever they want. There's no real accountability. Or choice, or there's no real accountability to kind of go wherever the heck they want. And so Tom said, okay, I've spent a lifetime accrediting centers and creating centers of excellence pathways, if you will, at other employers. What if I started directing this small pocket of people spending all the money to the best centers in the world that do not misdiagnose and do not overutilize, understanding that we have an absolute epidemic of misdiagnosis and overutilization. So sure enough, fast forward, that's what Tom did at Walmart. That became the Walmart Center of Excellence program, saved billions of dollars on the health plan, literally moved the stock price for Walmart at one point. A bunch of employers, probably like you all on the call today or the webinar today, a bunch of self-funded employers started reaching out to Tom and saying, hey, Tom, how can we get one of these? We don't have the horsepower of a Walmart to go in and dictate and do all the different things that you did. We certainly don't have the expertise to make that happen. How can we get one of these? And so Walmart allowed Tom to clone it, and that became Edison Healthcare about 10 years ago. Fast forward several years, Tom called me. He just wasn't growing the operation. He's a benefits guy. And so he called me and said, hey, Sean, could you help us grow? And I said, absolutely, happy to do that. And so I got involved and then officially acquired the company in fourth quarter of 2017 and moved it to Tulsa, Oklahoma, of all places, because that's where I live and I wasn't going to live in Cleveland. So anyway, that's kind of the history of Edison Healthcare. Now I'll get into the nitty gritty unless there's no questions, but you heard me say it, guys, 6% of the enrollees are spending all the money. And I will guarantee it, if I could look at every one of your health plans today, that would stand true. I don't care if you have 28 employees or 28,000, doesn't matter. A small pocket of people are spending all your money. But what do we know? And we have a lot of data. Yes, our covered lives, which is significant. We've got employers like Rubbermaid and Coleman and Hertz and Every K. Jarrett and Zales Jewelers and Calphalon Cookware and Yankee Candle and Sharpie and Elmer's Glue and large healthcare organizations like Kindred Healthcare, et cetera. So our largest employer is 130,000 lives with 1,700 locations, all the way down to my favorite employer that's 28 employees. And what does that tell me? That tells me that we can work with anybody big enough to be self-funded, that we can integrate with the BUCAs. And so I have lots and lots of lives. Walmart's a great partner of ours from a data perspective, thanks to Tom Emmerich. And then our smart centers share all their data, our smart care centers, which is what I call centers of excellence. So what do I know? Of that small pocket of people, 20% are going to be completely misdiagnosed, and another 40% are going to have wrong or suboptimal treatment plans. I don't think I have control of the slide deck. Could you, there we go. So this kind of illustrates some of those things. You can see here, 6 out of 10 spine surgeries in Edison do not happen. That's, you've been told, let's say you need a fusion in your local market. You go through our program and find out you don't even need a fusion. or that surgery to begin with. I would say spines is probably the biggest offender in healthcare overutilization in America. It is, I mean, it's called cowboy doctors. Give it a Google. It's a multi-trillion-dollar industry. But, you know, I won't read all these guys, but 35% of all cancer in Edison is misdiagnosed. And I never thought in a million years when I took over Edison that I would hear this story hundreds and hundreds and hundreds of times. You've been told you have cancer in your local market. Maybe you started treating for it and you find out you don't even have cancer. You go through our second opinion program and Care If You Need It. And you find out you don't even have it. It's unbelievable. Next slide, please. Michael, am I able to control the thing? I can't tell.
I'll see if I can figure it out while you're talking, but
okay.
You might just have
yeah,
to...
all good. If you don't mind moving it for me, that's fine by me too. So this kind of further keeps reinforcing my point about misdiagnosis and overutilization. We are overstenting people in America, and it's direct correlation to death. This was a study done by Dartmouth, and you can see here, the dark blue are the worst offenders in America. The subsequent lighter shades are a little bit less worse. But check out Arkansas. It's the one that's most glaring to me. That is one hospital in Little Rock, Arkansas that I am not over-exaggerating when I say they are butchering people. This is public knowledge. You can definitely Google it. But to give you some context, we took a call from a guy in Little Rock, Arkansas. He was with Dillard's, actually, a Dillard's employee. And he heard about the Edison program. It was fairly new at the time to him. And so gave us a call. He heard copays and deductibles are waived, you know, all the cool things that we do that I'll touch on in a moment. But so he called us. And the guy in 2.5 years had 10 stents in his heart. I'm not even sure how that's physically possible to have 10 stents in your heart, but I've seen it all, it seems like at this point. But nonetheless, they wanted to put an 11th stent in this guy's heart. This same hospital, 11 stents in 3 years. Unbelievable to me. And so he's like, I need help. Something's got to give here. So we did something very simple with this guy. We ran a pharmacogenomic test on him, because what's the first thing that stuck out to me and to our smart centers, our doctors, is that he's likely not metabolizing the medication that he's taking. It's not working. It's not helping. It's harming him. So for $150, we ran this test on him. The test is super complex and way above my pay grade, but in the middle of it, there's a simple red light, yellow light, green light of the drugs you can and can't take. Super easy to understand and to comprehend. Well, sure enough, this guy was taking the drug Plavix. It was on his red light panel of things, do not take this drug, and nobody thought to even look at that. So we simply switched the drug. We ran him through our polypharmacy protocol at one of our centers. They switched the drug. He didn't need the 11th stent, and it's unfortunate he was advised that he likely didn't need the 9 others had they just switched the medication. Unbelievable to me, but that's healthcare in America. Next slide, please, sir.
All right. Hey, Sean, I'm giving you remote access, so you give it a whirl. If not, I'll still advance it.
Yeah, it's not letting me. I'm sorry.
All right. No worries, bud.
So to speak to spine surgeries, again, misdiagnosis, overutilization, I'll draw your attention to the second and third rows here. Patients receiving fusions, the national average is 43 per 1,000. Edison Smart Care is at 32.5 versus Hospital B. So who is Hospital B? This is a Blue Cross Blue Shield distinction center. If any of you are with Blue Cross, you know or have been in the past, that is their term for centers of excellence, doing fusions at 2 times the rate. But the one that's most alarming to me is the third one. Patients receiving 4 or more vertebrae fusions. This is a horrible, horrible surgery and should not happen very often. Unfortunately, it does. The national average per 1,000 is 7. Edison Smart Care is at 0.63. Now, I've seen this diagnosis usually a result of some sort of revision or redo, if you will. Employers in America are paying for revisions and redos on joints and spines at a ridiculous rate. You may not even realize you're doing it. It's unfortunate. Edison is so confident. You can see 0.63 per 1,000. We are so confident in our ability to diagnose correctly and do it the right way. Our single case rate for the price that you pay, the bundle that you pay for our care, we include that. We go on the hook for the revision. The employer never has to pay for our mistake. And we're very confident in our ability not to do that. And I don't think anybody's doing that now. versus Hospital B. Again, Blue Cross Blue Shield Anthem Distinction Center, 27 times the rate of redos. Not 27% more, 27 times more. Pretty staggering. Next slide, please. So if you've ever heard Tom speak, he'll tell you the biggest quality issue is the least managed and the appropriateness of care. Tom has been a great friend and mentor of mine for, golly, 10, 15 years. Taught me so much about employee benefits, it's not even funny. And I've never really let that statement sink in until I really got involved with Edison. I always thought he was just talking about patients, you know, that typical, they're in a PPO, they just kind of go wherever the heck they want. There's no real accountability. That's not who he's talking about. He's talking about the doctors. He's talking about the surgeons. Plain and simple, they're paid to cut. They're paid to prescribe one thing over another. And that's unfortunate. And there's little to no performance management or accountability. Next slide, please. These are some articles that speak to that. You know, like I've said a few times, give it a Google. They're in abundance. They seem like, I think they come out every week. Next slide, please. These are some of the employers that take advantage of our model of care. You heard me rattle off several earlier. Next slide. So I'm going to go through these next two slides pretty quickly, and then I'm going to tell you how we're doing it. What's the secret sauce, if you will, for what we're doing. So we're assisting the outliers in getting the best treatment and advice in the world. So who are the outliers? Those are the knees, the hips, the spine, cancer, heart, transplant, all those high cost claims that are killing your plan. And we're getting the diagnosis correct. Next slide. We're applying ethical, surgical, or other treatment solutions, which assures great quality outcomes. And then we are concierge medicine at its finest. So airfare, lodging, meals, or mileage are covered for patient and caregiver to go to one of our centers. Next slide. So this is the secret to our success. It's these dots on this coverage map. And I've actually recently added a couple more that I haven't officially announced, but I've got one coming in Texas that'll show up soon. I've got one in Indiana, two in Denver, and one in Phoenix popping up pretty soon. That's actually one of the reasons I'm here today in Arizona. But this is the secret to our success. These are our smart care centers around the country. I jokingly call us a PPO by disease, not by geography. These centers have gone through our 15 to 20 month accreditation process. We are under the hood of these centers. We are under the hood of these providers, literally changing the way they do business. And it's a proprietary thing that Tom created through, you know, years of a lifetime of doing this. And so that's what we do. This accreditation process really comes down to what we call our 4 pillars. These 4 pillars of accreditation are the reason why we've never lost an employer in our 10-year history. Our patient satisfaction is over 98%. I can go on the hook for those revisions you heard me talk about. And our ROI is through the roof for employers. So we have a proprietary ROI calculator validated by the Validation Institute, which is very well known in the Health Rosetta world. And I can conservatively tell an employer of any size how much they will save by accessing Edison versus going through their standard network pathway. We are outperforming that prediction with every single employer in our network in real time. We predict about a 4.5 to 1 ROI. Our smallest ROI in real time, and I get this report every Friday, is 7 to 1. Our biggest ROI is over 40 to 1, which is pretty significant. So it's these 4 pillars. So what are they? First and foremost, speed to care. Very much doctor, the patient will see you now. Very much when you call, we move quickly on your behalf. There is no wait. You're picked up from the airport. You're taken to your hotel. You're picked up from your hotel, where you're escorted every step of the way through the center with a direct liaison. There are no waiting rooms. Huge deal. The second pillar, multidisciplinary diagnosis. Sounds cliche. A lot of centers throw that around, but it really is important. You see all these things I have listed here on the left. Most of the folks dealing with these pathways have other comorbidities associated with whatever they're dealing with. Maybe they're overweight, maybe they're diabetic, maybe they're taking 4 million medications and they got to get that sorted out. They have a heart condition, but they're there for a spine. Who knows? But it's important that a multidisciplinary team addresses the needs of every patient, of our patients. The third pillar, addressing that cowboy doctor kind of mentality. oh, whoops, oh, there we go. Addressing that kind of cowboy mentality. 98+% of all of our clinicians are salaried. They are accountable to the center. They are accountable to us and the things that we put in place. They are not paid to cut. Very, very important piece to what we do. The fourth pillar is the absolute most important thing. We will never allow a single clinician or their multidisciplinary team, that pillar number 2, to determine a diagnosis on their own. They are required to double, triple, and quadruple check every decision that they make before a board of their peers that we have hand selected in conjunction with them. So we do that fourth pillar for one very important reason. Mayo did a study, a couple years back, it's public knowledge, brought in several hundred of the best clinicians in America of varying disciplines. They gave them all imaging, pathology, labs, and a blind study. They had no idea who the patient was, but they were told, hey, come up with your diagnosis and then go on about your business. So they did that. They left. They came back 90 days later. Unbeknownst to them, they were given the exact same patient. They had no idea. And I bet you can guess what happened. Over 43% of the time, they changed their diagnosis just in a 90-day period. So what does that tell me? It tells me that I don't care how smart you are, how much education you have, you're human, you're gonna make mistakes, and it's important that you have checks and balances in place to ensure that happens. And that's why we do that fourth pillar, and I'm telling you that's why we've been so successful and our ROI is so high. On the left here are all the things that we do. I know complex care at the bottom seems really generic. It's because employers lean on us for everything. I mean, we've got 2 twin babies in the womb right now with spina bifida, just to put some context around it. We manage MS patients, hemophilia patients, you name it, we manage it. Next slide, please. So this does a really good job summing up a lot of what I said, but I will hit on a few key areas. Structure, you heard me talk about multidisciplinary and salary-based. Outcomes, we're always monitoring our centers. So yes, that 15 to 20 month accreditation is extensive. It's important. It really matters. But what happens after, Sean? Like, well, how are you guys staying on top of these centers once you leave? Obviously, our patient satisfaction and patient reported outcomes tell us a lot. But we use a third-party accrediting body, company called BKD, well-known nationally. They follow all of our accreditation metrics and all the different things and go see our centers annually or semi-annually. Philosophy, I'll touch on 2 things here. Evidence-based quality. What does that mean? Very, very simply, it just means I will not work with an education facility under no circumstance. A university of this hospital, a university of that, Johns Hopkins, all those. They all serve a great purpose. Research, all of that stuff matters. New technologies, it usually comes from places like that. I get it. I'm just not going to allow my patients to be part of that. And so what trumps patient care at an education facility? A few things. Grant money, research money, super important. Training of the residences, you know, the doctors in training. It's very important that they get their training, but not on my patients. And third, you know, like that.
Hey, Sean, not sure if you can hear us, but your mic cut out. You might have an internet issue. Huh. All right, well.
Yeah,
You there?
that's so weird. I apologize. It just shut me off.
Too passionate, bud. So yeah, tone it down a little.
Sorry about that. Nonetheless, I apologize for that, but we're always evolving. So, you know, we've got Sean, we have a major issue with addiction on our health plan. Can you come up with something that works for that under kind of the Edison umbrella? So anyway, always evolving, always listening to what our employers and benefit consultants are telling us we need to be doing. Financials, guys, you haven't really heard me talk a whole lot about cost because I'll just be completely frank. Who gives a crap about a deep discount on a surgery you never needed? And so, you know, I always joke, how do you save 150% on a spine surgery? You don't have it. And so, you know, that's price is not our thing, but we do check the price box. So our case rates, our bundles for everything that we do when we go on the hook for those revisions are blowing the BUCA pricing out of the water. It's truly, truly strong pricing. The reason I don't care about pricing is because I feel like I have an obligation to be priced right. It shouldn't even be a conversation anymore. The discounts and all of those things. I get it. That's healthcare in America, but that is definitely not Edison healthcare. The true ROI is stop paying for things you should never be paying for. And that's a big deal with us. Next slide, please. So I won't get too much in the weeds on this. Certainly, if anybody has any questions, I can get in the weeds on it, but or we can meet offline or whatever you want to do. I'm sure Mike will do a good job of teeing that up. But nonetheless, just a couple quick points on here. Employers waive copays and deductibles. It's 100% covered if you go through Edison Healthcare. Obviously, if there's a high deductible health plan in place, we have a really cool kind of tier 1, tier 2, tier 3 type of thing where Edison's considered tier 1. It's lower to the federal minimum. And you know what we found is when most employees are engaging us, they've usually met that, especially when it's at the IRS minimum. Employers cover the cost of travel. Obviously, the ROI makes a ton of sense based on what we're doing. Next slide, please. So what are we doing? Well, you heard me say it. It's concierge medicine at its finest. So it's hand-holding, white glove, whatever you want to call it, approach to healthcare. So we're managing all the eligibility for the members. We're coordinating with the BUCA, whatever BUCA plan you have, your stop loss if applicable, all of those things. We're coordinating the referrals into our smart care network. Our smart care center is retrieving the medical records, communicating with the employee or the member, whatever's going on. We're arranging all the travel logistics, et cetera. We're supporting them every step of the way. Next slide, please. Now, plan design is a biggie, and this is a big one for me. And I was really excited to hear Kristen talk about plan design, things that they do to direct that traffic. And Kristen, as a sidebar, I'm really interested in speaking with you. We'll have a little over 500 employers at 1/1. And I have a lot of employers that would be very interested in learning more about what you're doing. But plan design is a big thing for us. And here's what we've learned. When I first took over Edison, I was just selling the crap out of it. Voluntary, let's keep our fingers crossed and hope you get an ROI. I found out it wasn't working. The engagement was super duper low. And so we started just going to mandate. 75% of all of our employers in our block today are mandated. They've either gone there to start or have converted to such. And of the 154 new groups we have going live between now and 1/1, only 2 are going voluntary, which is unbelievable. It tells me employers are getting it. They are tired of settling for subpar care. They're tired of paying for things they should never, ever pay for. And so they're putting in the plan document. If you go to Edison Healthcare for your spines, your joints, your cancer, whatever you want to list, we're going to pay 100% of it. If you go anywhere else, we're just not going to pay for it. Or we'll cover it at a lesser benefit, like 50% or something. So that's what our folks are doing. We have a one-time implementation fee only. If you do the mandate, and I consider a full mandate, pick 2 of our 3 main disciplines. We consider that a full mandate. Most of our employers do 3 or 4. It's $5,000 one-time setup fee. If you do voluntary, meaning we're just going to keep our fingers crossed because it's a good news message and see what happens, $30,000. Now, even at 30, you avoid 1 spine, you're getting that back in spades. But nonetheless, that's how we do plan design. Guys, I don't charge a PEPM or PMPM. There are no admin fees to be a part of Edison, none whatsoever. How can I ethically look an employer in the eye and tell them, yeah, I'm only going to manage 6% of your population year over year, but I'm going to go ahead and charge everybody. It doesn't make any sense. So you only pay when you use Edison. We get a flat fee anytime someone travels. Next slide, please. So you heard me kind of talk about the value of Edison. You've heard me say it 100 times already. Misdiagnosis and avoidance of surgery, management of complex care, case-rated pricing. So all that pricing is case-rated or bundled or whatever you want to call it. And then no admin fees, which is huge. And that's pretty much it, Mike. That's all I got. This is just talking about implementation. I could get into that another time. It just what's next steps and how all that works. But
I got a little trigger happy. Sorry about that, Sean. So, hey, let me ask you a question. And I want to see if there's any other questions out there. I was trying not to mess up the flow of the presentation, but you can see I got a little trigger happy on a few of them. So when you had the slide up there about surgery avoidance or and that type of thing, I guess I had a conflict, conjures of old memories from when I was first in the business almost 30 years ago about the whole HMO, you're going to avoid care versus the one of making sure it's the appropriate diagnosis. And so can you talk a little bit about when you say avoiding care, I'm assuming it's a relief, not a burden for the patient. Is that correct?
Absolutely correct. Guys, for these complex issues, knees, hips, spine, cancer, heart, transplants, bariatric, pediatric rare things, whatever, always, always, always get a second opinion. You have to. The appropriateness of care is a massive issue today in America. The HMO is, obviously not a great solve for healthcare in America, but its intent was probably good. It was to be sure things were being focused and streamlined into the right places. The issue was the places weren't right and they weren't doing things appropriately. It is so important you get a second opinion, a third opinion if you've got to get it, but you got to go to the right centers who are doing the right things. And unfortunately, having a center of excellence in every major community in America doesn't exist. I'm sorry, it doesn't exist. And it's important that you get the right opinion. So you're absolutely right, Mike. It is a relief to be able to sit in front of a multidisciplinary team. They're not shortchanging you on your care. I mean, you're getting a full-fledged second opinion and being told you don't need to take those 10 medications. We need to streamline this. You need to take 2. And I'll tell you what, a funny thing, and I don't mean to get off on a tangent, but a funny thing with us, our patient satisfaction is over 98%. I think it's 98.6% or something like that. That 1 point whatever percent of patients dissatisfied, the vast majority of the time, it's because they're ticked off because they didn't have the thing they wanted to have. It was a part of their identity. We took them off those medications. We told them, you don't need this spine surgery. You need to do these things. And that's whenever we have a dissatisfied patient, it's usually because they identify with whatever pain or disease they have or all the medications they have. It's part of their identity. And that's been a real funny phenomenon for me to see in healthcare since getting involved. Our people's identity are dictated by pain. And it's really, really interesting. Excuse me.
Yeah, so Sean, that's a question I would have is you made a reference back to the centers of the Blue Cross Centers of Distinction. Every health insurance plan has a center of excellence, if you will. And one can argue and say, look, well, you're channeling people that are either, you're giving them more folks, so shouldn't they have a higher complication rate? What is your response to that?
Yeah, so I mean, it's a great question. And really, Mike, those distinction centers, they're not all bad. I'm not suggesting that Blue's distinction centers are all bad at all. What I am suggesting is the criteria by which they measure those centers is deeply, deeply flawed. And I see that every single day. So, high frequency doesn't mean good outcomes. It just doesn't, plain and simple. That center that I used for an example there, I didn't touch on this because I was being considerate of time. But, I've been on the carrier side a lot in my career. I have a handful of other companies in this healthcare ecosystem. And so I've done a lot at the BUCA level. And when I started doing the study on that particular center I was pointing out, it was an Anthem center. And I have a lot of buddies there, a lot of executive buddies. And I said, how in the world could this be a center of excellence when in fact it's a center of unexcellence? It's absolutely horrible. And he goes, well, Sean, they have good outcomes. And I said, well, you can have a good outcome on a spine surgery you never needed. And he goes, well, that's true. And he said, well, they have great infection rates. And guys on the phone here, never judge a center by their infection rates. That is the biggest smoke and mirror center of excellence criteria in the history of healthcare. These centers pick and choose who they want. They send patients off to other centers. It's unbelievable. But nonetheless, what I found was that Anthem Center is a tier 1 center, which simply means they take a deeper discount in exchange for volume. Run the opposite direction if you hear someone's a tier 1 center. Never, ever go to that. So anyway, hope that answered your question, Mike.
Yeah, and that was kind of a softball. I knew the answer to that one, but I wanted to ask because I would imagine that a question could be begged about that because some of this stuff is, I don't know if it's controversial, but it goes against the grain of a traditional message you've been hearing for 20 or 30 years about a center of excellence, and that you send all of your volume there because there's a massive amount of specialists. And what you're saying is, it's not necessarily the best place to go. You've got to look at all the elements, not just price. And so, yeah, you're kind of giving away a better discount for volume, but it doesn't necessarily mean it's the greatest quality of care. Let me ask, in terms of some of the things, the reason that I wanted both of you to speak today was that you guys could work alongside a traditional health plan. Kristen talked a little bit about that, but Sean, in the concept of a mandatory second surgical opinion, how do you do that if the incumbent plan is not a TPA that will essentially be the swing arm to say, well, for this surgery, we need you to have a second surgical opinion? Does that make sense?
Yeah, absolutely. So some of those employers have, and Kristen's probably very familiar with this, they have those care navigation platforms, the Quantums, the Accolades, the Aletheus, the Narises, and all the programs out there who, in theory, are supposed to do one singular thing. Mm-hmm. Engage members early, get them where they need to be, period. That's what they should be doing. Unfortunately, I don't know that it works quite well just yet. The mandate, what does that do for you? If the mandate is in the plan document, when Mike is told he needs a knee surgery, whatever, hey, Mike, I think you need to see a specialist. Mike's going to go to whoever specialist maybe he chooses. Maybe he hasn't heard about Edison yet, or maybe he has and he's just kind of forgotten. They're gonna before Mike shows up, that specialist is gonna verify benefits, eligibility, what's Mike's out of pocket, what is it gonna look like, and that plan design and the plan, that language in the plan document is gonna trigger it. Mike's got to call Edison Healthcare. So I can't tell you how many times we have centers all around the country calling us saying, we have one of your patients. We were calling to verify benefits on one of your patients. That can you allow them to come here? And it's like, no, we've got to speak with them and we direct them through our program. But that plan design, that mandate is super duper key. But some employers, like we work closely with the Quantums. We work with those TPAs who want to do pre-certs, pre-certifications, and those things. And we have some very unique things, but we've been super successful in getting the BUCAs, Blue Cross United Cigna Aetna, Meritain, UMR, all of them to play ball. And it really has become a moment of the employers on board, the benefit consultants on board, Edison is certainly on board, UMR, you better get on board. Mm-hmm. And we better have some productive conversations on how to make that happen. And I'd almost bet that Kristen has a similar experience as far as integrating with the BUCAs, is just, guys, get on board. This is happening, whether you like it or not. And so, that's something that we've been very fortunate to make happen.
Yeah, and Sean, great point, because you're right. The most people have an SPD in place because they need to have something, so they have a rule, so they can say, hey, if we're ever audited, we have a rule book and it's compliant, right? Where what you're talking about alleging is that, look, when I say you write the check, you should write the rules. Having that mandate in the plan document is exactly that. That's the influence. That's the power of the pen. That's creating a sword and a shield. And so, yeah, that's just a great example of that. So thank you for sharing. Are there any questions from the audience at this time? All right, well, I'll just open up for questions. If there are questions, please ask them now by typing in the chat. If not, there's nothing against ending the meeting early, huh?
Yeah, that's right. That's where you mic drop when there's no questions.
Yeah, what I would say, Sean, is one of the things that, I talk about my wife's journey, and that she has a condition that we kind of floated around the healthcare system, went to an educational hospital, thought we were getting the best care possible, but we realized we weren't at all. And the challenge that we had was finding the quality physician for her specific disease. You can't go to a Blue Cross or a United through their network and say, hey, give me the top doctors in the country for this condition. And so we actually found the doctors, the 5 best in the country, on Facebook. And so having a service like yours in place where you can say, look, this is either a new diagnosis or one that, you know, or whatever, but having the centers in place that can essentially effectively give you as the individual the power of knowledge of here's the treatment options that you have. And not only that, it's either affirmation that you need the event or validation that in fact you don't. And so it's just a fantastic service, because having been a part of an experience where it was probably longer than it should have to get the diagnosis correct, and who knows how much suffering that my wife went through for surgeries that didn't need to happen, but being able to shorten that would have saved a ton of money for State Farm. She's a State Farm agent, but the bigger impact would have been the avoidance of the suffering and the well-being she would have had. And so, as I've said before, that's part of my mission. My wife, she motivates me every day. And part of that is by learning through her experience. I have to share that with the world. So I'm very privileged to have found folks like you, Kristen and Sean, to help with that. So if there are no other questions, I will say thank you all for your time. For our audience members, we're going to be sending out a copy to you of the Dave Chase's book, The CEO's Guide to Restoring the American Dream. And you're probably getting that next week. Sean and Kristen, thank you so much for your time. It's a pleasure and a blessing to have you.
Yeah, my pleasure.
Enjoyed it.
Thanks so much.
Thank you.
Thank you. Bye-bye.